Hi, everybody. I know it's 11, but I think we'll give it just a few more minutes because I see people still logging on. So we'll just a couple more minutes. Thank you. All right. Thank you so much, everybody, for joining. I'm going to go ahead and get started because I know everyone has things to do. And I really appreciate in the midst of all the craziness around us that you took the time to join us today. As most of you know, my name is Dr. Vinita Tandon. I am the medical director of the BHRT program here at Jumpstart MD. And we've been doing a series of short webinars just talking about hormone therapy. And today's kind of concludes the series, and the topic is testosterone therapy in women, and mainly addressing just some common myths and hopefully answering some common questions surrounding testosterone therapy. I'll hopefully address most of the questions, but definitely please feel free to use the Q&A tab if you have any questions that I haven't answered, or really this is a chance for us to have an open discussion. So I definitely appreciate your participation, and we'll keep it informal, and so ask away. You can use the chat or the Q&A, but I think the Q&A works a little bit better. Before I begin, just a reminder that we are, because of the success of this promotion, we are continuing it for a little while longer. It's basically a discount for any referral for either weight loss or for BHRT. If you refer somebody, a friend, yourself, the minute you sign up for a consultation, we will cover all the hormone labs, and that's usually valued $600 to $900. So it's a pretty good deal. I think they agreed to extend it through September. So you have a few more weeks to take advantage of it. All right. So today's topic, like I said, is basically talking about the importance of testosterone in women. And one of the most common myths is that only men produce testosterone. And when we talk about it with our female members, they're so surprised that it's something that we even are able to test and something that we talk about. Even though it is thought of as a male hormone, it plays a very significant role in female health. It's actually the highest circulating sex steroid in women. We always kind of put a lot of significance on estrogen and progesterone for a good reason, but testosterone is right up there as a very key hormone for overall well-being. We need it for energy. We need it to maintain a good libido. It helps us maintain muscle mass, bone density. It keeps us motivated, ambitious. We feel engaged in life when our testosterone levels are normal and optimal. In women, there's kind of three areas that produce testosterone. The ovaries produce about a quarter of it, the adrenals another quarter, and then in the peripheral tissues, about half of testosterone is produced that way. But because the ovaries account for about a quarter of the production, when we age and go through menopause, just consequently the testosterone production also declines as a part of that. And for some women, they may not notice that decline and they are able to kind of coast and do fine. But for probably the majority of women, they do have symptoms that could be subtle or not so subtle and that are associated with testosterone deficiency. Some women don't even realize, but they've had low testosterone for a majority of their life. And they've always had symptoms consistent with what's known as hypoactive sexual disorder, or HSDD, which is where you have a really low libido that's almost debilitating. It affects relationships, quality of life. So it's interesting when we take a history, how many women acknowledge that they may have had low testosterone for a very long time and just it was never checked and not diagnosed. So myth number 2 is that testosterone is not clinically important in women's well-being. And I think this stems from the fact that the medical community has been so slow to appreciate the importance of testosterone in women. And so it's just not addressed in a typical doctor's visit. However, one of the most prominent symptoms of low testosterone is low libido. And this can be a variety of symptoms, but typically textbook-wise, it's defined as having decreased sexual thoughts and fantasies, decreased sexual actions, decreased arousal, decreased orgasmic response, decreased vaginal lubrication. Women will say that they just stop being the initiator. They may still be intimate with their partner, but it's more kind of out of obligation to the partner. They themselves could take it or leave it, so to speak. And this can cause tension in a partnership, this lack of intimacy, and if there's a mismatch in libido between the two partners. There was a nice study published in the Journal of Sexual Medicine, which actually was one of the first kind of prominent studies that was done to really show the correlation between testosterone levels and sexual desire. It was a cohort study looking at about 560 healthy women aged 19 to 65, and there was a direct correlation between libido or desire and their free testosterone levels. Other symptoms of low testosterone: decreased muscle strength. Women may notice that they used to be able to lift a certain amount of weight routinely, no problems, and now they feel kind of weaker and weaker. Their strength isn't there. They may have decreased energy overall. They may sleep well, get 6-7 hours solid sleep, but they're kind of just dragging the whole day. They've lost that get up and go type of feeling. Decreased motivation. Women often complain of just some apathy. They don't feel as ambitious. They don't feel motivated to do the things they've always loved to do. Maybe at work, they also acknowledge that they're not as motivated. They don't feel as engaged in what they're doing. Difficulty maintaining muscle mass. They haven't changed their workouts. They're still going to the gym or seeing a trainer, and yet they have a lot of difficulty maintaining good tone, muscle tone. They notice more belly fat. They start to notice kind of that tire around the middle. They may have never had any problems with belly fat in the past, and now they see that's kind of the problem area where their midsection tends to accumulate the most fat. Decreased endurance, stamina, more senior moments, just that forgetfulness, that difficulty with word recall or name recall, they notice that. And if I had to sum it up, I would just say that women just notice they've lost their mojo, that for whatever reason, they're just not as engaged in life or their surroundings or their relationships, and testosterone can play a big role in these symptoms. one of the questions that we get asked, especially at Jumpstart, where we have a significant portion of our members who are trying to lose weight and are part of the weight loss program, they want to know if low testosterone is contributing to their metabolism and their body composition. And the answer is yes. It plays a huge role in body composition. When you have low testosterone levels, it can reduce your lean muscle mass and increase your body fat mass. So both the muscle and the fat are going in the opposite directions of where we want it to go. And there's kind of this vicious cycle of having low energy, low stamina, decreased muscle mass, and it just feeds the cycle of obesity and weight gain. Also, there's an independent relationship between testosterone and visceral adiposity, that's fat inside surrounding the organs. And we see that when you have more visceral adiposity or fat in the midsection around those organs, it triggers this cascade of insulin resistance, high blood sugars, high cholesterol, the bad kind of cholesterol, high blood pressure, and then this pro-inflammatory state. We know that fat cells are kind of the main location where inflammation takes place. So the more fat cells you have, the more inflammation you have. There's also a significant association between testosterone and bone mineral density. As we age and we lose testosterone, we have a kind of an undesirable change in our ratio of bone building cells and bone destroying cells. And especially if we're also maybe genetically predisposed to osteoporosis, if there's a strong family history, maybe our diet is limited, we don't get enough calcium or vitamin D, you're just, you may be a frail body type, you're more at risk of osteoporosis anyways. And then compounded by the fact that you have low testosterone, it can just really increase your risk for hip and vertebral fractures. You start to shrink, you lose height, and you start to have that kind of classic hunchback look. JCM, which is the Journal of Clinical Endocrinology and Metabolism, published a study in 2011 where they just looked at women over, ages 67 to 94 and measured total and free testosterone. And free testosterone was positively related to hip bone mineral density and lean body mass. And they found that there was a more than 10% difference in both bone mineral density and lean muscle mass between the women at the highest free testosterone range and the lowest free testosterone range. And just, an aside, muscle mass and bone mass really go hand in hand in terms of your risk for hip fracture. If you may have good or okay average bone mineral density, but if your muscle tone is weak, if you fall or you are skiing and you tumble, if you don't have the muscle tone or the ability to correct yourself and save yourself from that fall, it also puts you at risk for a fracture. So it's so important that both your lean muscle mass quality and quantity are intact, as well as your bone mineral density, to help prevent vertebral and hip fractures. And as we know, hip fractures are a main cause of morbidity and mortality as women get older. So one question we often get asked is, how do we diagnose low testosterone? And it's a little bit of a multifactorial thing. Definitely labs are part of that. We want to see what a woman's total and free testosterone levels are, but that's only part of the picture. We definitely also take into account symptomatology. Is there osteoporosis? Where are they in the menopause timeline? All of those things. Labs wise, it's a simple blood test. We check a total and free testosterone. When you're menopausal, it can be checked at any time. If a woman is premenopausal, we time it with their cycle. We look, even though we check both, the free testosterone is better correlated with bioavailable or active testosterone. So we pay a little more attention to that number. And the Mayo Clinic labs, this is their published reference range by age. And you can see, it's unfortunate, but even at 0.6, which is quite close to 0, that's considered acceptable. And we really disagree with that. I don't think I've met any woman who was in this range who felt good. So really, we're trying to get to the higher end of the normal range. And some women, this is kind of a guideline, some women actually prefer their free testosterone to be double this. They're in the 20s because that's where their sweet spot is. That's where they feel best in terms of their energy, their libido, their muscle mass, and they don't have any bothersome side effects. And so that's kind of where we dose them to. But in general, our testosterone levels peak around age 18 to 20. So that's what we strive for when we restore or optimize testosterone therapy. We kind of want to go back to those more youthful levels where our bones were the strongest, our muscles were the strongest, we were the leanest, we had less belly fat, our cognition was best. So that's what our goal is. Another myth is that testosterone therapy is only available and only beneficial for men. That's definitely not true. I love this little picture because it really shows all of the benefits of testosterone in women. Energy, prevents depression, reduces anxiety, increased mental focus, overall well-being, stronger bones, better orgasms, better sexual function, improves body fat, cholesterol, blood sugars. Because you're more active, you're more engaged in the day, you may even sleep better that night. It just kind of sets you up for a much more positive cycle. The British Journal of Sports Medicine did a study, and it was double-blind, randomized, placebo-controlled trial where they had women athletes apply testosterone cream on their thighs for 10 weeks. And they found that their endurance improved by more than 8%. And with very little rise in testosterone levels, I think it went up to 2 to 4-fold, which is still much less than men's, but it had a huge improvement in their endurance and stamina. And this was based on their running endurance. So another question that we talk about in our consultation is what are the different testosterone regimens? And the most popular at Jumpstart are the pellet insertions. They've been used in women since 1938, so over 80 years. And they are inserted every 3 months, usually into the butt cheek, just that fatty layer. And the reason it's so popular is because there's no mess, no fuss. You just have an appointment every 3 months, which is pretty quick in and out. You get very stable dosing, very stable levels. We have multiple pellet doses, so we can really customize the dose that we give you. It's very individualized. And most importantly, there's no worry of transference and kind of user error. You get to be free of worrying about, did you apply the cream that day? Did you not? Did you touch anyone after you applied it? It's just super convenient. And the side effects, the only thing with the pellet insertions, for about 5 days after the insertion, you can't soak the butt cheek in water, so no swimming or hot tubbing or taking baths. Showers are fine. And for a couple days, we advise against any strenuous gluteal exercises like squats or lunges. But other than that, the risk of pellets getting infected or coming out are very, very low. If for whatever reason someone opts not to do the pellet insertions, then our next choice is testosterone cream. And again, this can give you very stable, consistent levels, but it's very user dependent. So it's up to the member to remember to apply it daily, ideally around every 24 hours in a consistent dosing fashion. It's typically applied in the inner arm, just under the armpit, where there's very little hair and the skin is kind of nice and thin for good absorption, or the outer labia. And the main downside of this is the risk of transference. So for women who have young kids at home or, like to wear sleeveless tops, we just caution that if you're going to hug somebody, you don't want to transfer the cream while it's active, which is the first 4 hours, to anybody else. If you apply it to the labia, then we advise just no intercourse for 4 hours after application. So you don't transfer it to your partner. One of the other myths that kind of is circulating out there is that testosterone treatment can cause masculinization and hair loss in women. And again, this is not true. Our goal is to kind of restore you to more where your levels were in your 20s. So clearly you're able to have those kinds of levels and without any deepening of your voice, no aggression, no hair loss. We don't see any of those masculinization features when we restore levels to those optimal physiologic ranges. The British Journal of Dermatology also wanted to put this to rest. They studied 285 women, treated them for a minimum of 1 year with testosterone pellets. They had symptoms of androgen deficiency, so they were given the therapy. And out of the 285 patients, 27% had hair thinning prior to treatment. And after treatment, 63% reported hair regrowth on testosterone therapy. And they also noticed that the women who had more hair loss prior to treatment had baseline serum testosterone levels that were significantly lower. So it seems like there is a correlation. If you have low testosterone levels, you are at risk for more hair thinning. And when we restore those levels, there seems to be a nice regrowth that happens. And of course, the most important question, is testosterone therapy safe? So we have lots of data. I just pulled a couple studies, but the one I liked was because they studied over 8,000 women. It was a nice large population, and they looked at 2 databases in the UK. Mean age of participants was 47, and they received all sorts of different testosterone regimens. Oral testosterone is much more popular in Europe, so that was one of the common treatments that they were given, intramuscular, pellets, or placebo. The average duration of follow-up was about 4.5 years, and they found no statistically significant differences between those on active treatment or placebo in terms of breast cancer, liver disease, cardiovascular disease, diabetes, stroke, blood clots, nothing. And this was just published in 2012. We also have really good data on the transsexual population, women who are taking supraphysiologic doses of testosterone to change into male hormone levels. And again, in that population, no concerns for cancer, mortality, breast cancer, vascular disease, nothing. And they're on much, much higher doses than what we give to restore our postmenopausal or perimenopausal women. Another thing we hear often is, well, my doctor would have checked my levels if they thought that I had a problem. And unfortunately, that is not true. The medical community, like I mentioned before, has been really slow to respond to testosterone deficiency in women. Low testosterone levels are often underappreciated, underdiagnosed. More often than not, clinicians or physicians will prescribe an antidepressant or recommend psychotherapy instead of addressing the root cause of the hormonal deficiency. They will say, well, it's just part of aging, or, maybe you're a little depressed, try this. And they never get to the root cause. They're much more likely to just kind of try these Band-Aids. And what's so ironic is oftentimes antidepressants actually worsen symptoms of low libido, increased body fat, low muscle, lean muscle. And so you're just spinning your wheels. And our goal really is to kind of break that cycle and get to the root cause. So I will stop here. Would love to answer any questions. Let's see if I can also find the Q&A tab. All right. Again, thank you so much for your time and coming. And I hope everyone's safe and okay with all the fires going out there. Feel free to call us, email us if you have any questions. Always here for you, and thank you again. Oh, sorry, I have one question that just came out. I just started testosterone cream and my face is breaking out. Any suggestions? Yes, so one of the kind of more bothersome side effects can be a little bit more facial hair. Usually it's peach fuzz or acne. Usually it's for women who are maybe more prone to acne. They're the ones who have a higher tendency to break out, but anyone can end up breaking out. We do have something called spironolactone, which is it's a once a day tablet that helps to minimize acne. Another alternative are topical preparations, either a mild antibiotic. Sometimes women use something like Accutane because that worked for them in the past. Usually we don't have to go to something that potent, but topical antibiotic or spironolactone are our first choices. Also, a cleanser that we like is one made by La Roche-Posay. It's a drugstore brand name, but they have a nice 3-step acne regimen, especially for hormonal acne. And so I would definitely recommend that too as a possibility. And let's see. Somebody asked, they've just started testosterone, how long to feel the results? That's a good question. On average, we say give it about 2 weeks before you start to notice some improvements in libido and energy. And it just gets better and better after that. In terms of body composition, improving muscle mass, reducing belly fat, that takes a little more time. Bone mineral density, we see big changes after about 6 months of treatment. Another question, does your body absorb the testosterone cream under the arm as well as it does on the labia? I've seen it absorb very well in the inner arm, but I do think there's a higher risk of it rubbing off just the way we walk, we wear t-shirts, clothes, whatever, hug people. So I do think it is still a better location to do the labia because you avoid all of that. But if you're super careful, you rub it in well, you don't let it rub off over the next 4 hours, you can get good results there too. I notice a lot of swelling around the labia area. Is that normal? That's not typical for testosterone treatment to affect any enlargement of the labia. Some women notice a mild, minimal enlargement in the clitoris area, but not so much in the labia. So we'd probably want to take that offline and maybe talk a little bit more about what the other possibilities could be, but that's not typical with testosterone therapy. Okay. Thank you again, and look forward to seeing you again next week, same time, around 11 o'clock. And the topic next week will be just a little more focused on weight loss, metabolism, and hormones. Thank you.